for the success of the Coalition for Compassionate Care goes to our next speaker, who is in fact Judy Thomas. They didn't give me anything to say about her when she found out and panicked about what I might say. So I have a script which I will read dutifully because I always do what I'm told. Some people aren't believing that. Judy Thomas is CEO of the Coalition of Compassionate Care of California. For almost 20 years, she started when she was 2 too. She has directed the statewide improvement of care for the seriously ill and their families at the end of life. But before I go any further, I have to also thank the Institute for sponsoring lunch. Forgot to do that. It's right here on my list of things. And you have on your tables a pamphlet about all of the courses they offer in palliative care, and you get a discount, which is always, I'm Scottish, I love discounts. So back to Judy. Just pretend I didn't say anything previously. Judy Thomas is CEO of the Coalition for Compassionate Care of California, and for almost 20 years she has directed the statewide improvement of care for the seriously ill and their families at the end of life. And she's going to speak to us about, we can do it, palliative care as a social movement. And we really are a social movement, and we can change care for this group of patients. So please, join me in welcoming Judy to the podium.
Good afternoon. Great, glad to see the slides are progressing. So, palliative care, oops, you know what? Let me turn on the lavalier. Okay. Definitely getting feedback. So we're going to try the lavalier and see if that works by itself. Do we have an AV suggestion here? So I think a lot of people are feeling like it is time to take palliative care into a phase of being a social movement. And a lot of us are feeling like it has been a social movement for many years, and what does that mean? So I spent a little bit of time thinking about that. And a social movement is a collection of people fighting against a common enemy or problem, or fighting for a common cause collectively, utilizing both inside strategies and outside strategies. So by outside, it's kind of outside the norm, kind of the minority pushing against the bigger society to make changes. But the goal ultimately is to make it a part of a broader society. So we have to be able to bridge from that outside strategy into things that do become and are part of mainstream. In order for a social movement to work, a lot of times we just are aware of social movements when there's one big incident or something that pops up, or there's a march or something that is carried by the media. But in reality, social movements are laid for a long period of time before they reach that point. And that foundational phase requires an infrastructure. So behind all the great social movements, there is and has been an infrastructure that existed beforehand and was able to take all of that energy and keep it moving forward and make progress. And some social movements have become very standardized, and some actually don't make as much progress as you expect and end up going away. Occupy Wall Street is one that really came up very quickly, was a lot of boom, but hasn't had a real staying power. In our arena, a lot of people talk about the natural birth movement, and we know that that did make a lot of changes with the way that birth is handled. So here in California, we have a lot of resources that we can use for a social movement, or taking our activities and really turning it more into the social movement phase. The Coalition for Compassionate Care is here, and we want to connect with everyone throughout the state who's working in this space, and we have that history of working with all the different players. So we have a broad penetration throughout our geographic community, but in addition to the geographic community, there's also a virtual community and a lot of things happening online through social media and digital media that we can leverage as well. So we want to start with that and then need to have this infrastructure in place so that we can keep growing the movement and keep bringing in and adding more people and more people. Oops, I'm going to stay with that one. So, and another issue with a movement, a key issue, is how do you frame your issue? Do we frame it as death, end of life, palliative care, serious illness? The framing that works with early adopters may not be the framing that works as you want to go mainstream. So how do we find kind of that balance there? Because a lot of people are really drawn to our work because of an experience with a loved one that didn't go well, someone who was either facing death or did die. So it is part of who we are and what motivates us to be here. But it's something larger than that as well. And there's a lot of people feel like death and dying and end of life is a kind of a barrier, that language, to the broader adoption. So I'd like you to take a moment and imagine for yourself, imagine life without death. Anybody having a hard time imagining that no one ever dies? What are some of the things that come to mind if no one ever died? Overpopulation. Traffic. So aside from this growing, continuously growing numbers of people, how about for you individually? What would that mean? More generations? More palliative care? So the reality is that mortality, that death, helps us understand what life is. We know something by knowing its opposite. Everything has an opposite. We live in a world that has polarity and duality, the North Pole and the South Pole, up, it has down, up and down, right and left, hot and cold. You know the emotion of the greatest ecstasy because you've known the deepest despair. So this not having death would really fundamentally redefine and impact what we think of as life as well. Mortality is part of our story as human beings. It gives us a beginning, a middle, and an end, and creates our journey as a story and a journey. And in fact, the fact that every breath you take, in some ways, is defined by the fact that at one point in time, you will no longer be breathing. But as long as we're alive, we are alive. Even though we know death is out there, we are alive. And we need to focus on being alive and in the present moment. So this awareness of death is kind of theoretical and abstract, balanced by our need to make progress and to be alive and make the most of every single day and to move our lives forward. When you're facing serious illness, that helps it break through this sense of like death is not just theoretical and hypothetical, but now it's something that's more personalized, that I have more awareness of. And often that's kind of what activates people. So I hypothesize that death is present around us all the time. We've just compartmentalized it. Mortality is a part of our collective stories. And I would like to share with you the fact that my husband has several superpowers, but one is the ability to watch movies. This man does an excellent job of watching movies. So we watch a movie or part of a movie every single night. So I'd say for the last 2 years, I'm going to just kind of underestimate it. Say I watched 2 movies a week for 2 years. That's 100 movies. And I started keeping track in my mind about the stories and noticing that some of them had to do with death. And so then I started playing this little game like, okay, well, I'm going to find a movie that doesn't have death in it. I would tell you, I've found one so far. And by death, I mean somebody dies, somebody's threatened with death, or somebody's backstory, their history, is part of their character, of who they are today because there was a death. So there's different types of movies, and some of them we're not surprised. When you think about it, movies about war, by definition, somebody's going to die or be threatened with death. Horror movies, the whole tension is that something terrible, really, really terrible could happen. That's what gives it the tension and what attracts us to those movies even. Some that are not quite so surprising, but you may not have thought about, is science fiction. Often there's a part of a death or potential for death. Superheroes are often protecting us from some horrible experience or potential. Thrillers, again, that tension is created because somebody's really at risk of some serious harm, if not death. Westerns, it's part of that culture of our Western heritage. And crime often is murder or something very, very serious. We're at the stage now where we're even having movies specifically about serious illness or death. We have the documentary we're seeing tonight, Extremis. You're Not You and Me Before You are both movies that take on a situation of where the main character has a serious illness that does progress and result in death. And then we have other ones like Still Alice, taking on the whole aging process and decline. But the ones that might surprise you, this clicker is a little slow. Oops, nope, then too fast. Okay. Are children's movies. Tarzan lost his mom. The trolls, the whole tension in the whole movie is that they might get eaten by the Bergens. You'd be surprised how many children's movies have an element of death in them. Romance often as well, whether it's somebody who actually dies or it's part of somebody's story. And comedies, even comedies. I was really excited when I watched Bad Moms, and afterwards I thought I found a movie that didn't have death in it. Because this, if you haven't seen it, it's a very raunchy comedy about some moms that get divorced and they kind of stop being the perfect mom. But then I realized, wait, the hot dad, he was a widower. So I challenge you to think about that when you're watching movies and just keep track of how much of it is an element in our stories and our history as human beings. And our world, I'd say our world is calling us to become more whole and stop compartmentalizing this. We're living in a unique time. Never have so many people lived with long-term chronic conditions, cognitive decline, and advanced aging. In California, the newest statistics are in 20 years, so pretty much all of us can fathom 20 years from now. It's not that long from now. 1 out of 4 Californians will be over the age of 65. So we're aging, we're living with disability longer, and at the same time, our world is becoming more extreme in all ways. You can see it with our politics, with the election. You can see it with our weather, going from extreme drought to flooding, so much water we can't even handle it. You can see it in our demographics. Santa Clara County has one of the largest number of millionaires and billionaires, and yet they have some of the strongest poverty and homelessness as well. So we have these extremes happening in and around us at all times. And when we shut off a part of ourselves, we become myopic and unable to tap that experience. All great truths are paradoxes. And I'm proposing that when we integrate mortality back into who we are more whole. We've all heard the saying, carpe diem, seize the moment, live today as if it was your last day. Mortality brings with it clarity and focus. And that can help us in a time of tremendous change. I think another reason that we're attracted to mortality is it's an element of the hero's journey. The hero's journey is a narrative that shows up across myths and much of storytelling that we have in society. It's about a person who takes on this journey to bring about a greater good for the group or the community in which they live. And you can see there's the calling, there's some mentorship. In the middle of this is really that tension of, am I going to live or not? Going through that fire of clarity. Going through that fire that motivates us to go beyond ourselves, to become bigger, better, stronger. And gives us the ability to do amazing things and bring that back to our community. So again, my theory is that death is a part of our story, our collective story and wisdom, and a part of healing. So what does that mean for the coalition and for what we're doing? Our 10-year vision is that everyone gets the care that they want and no more, and the care that they need and no less. On the palliative care side, what that means is that palliative care is just a normal part of our everyday healthcare system. Oops, went a little too far. And I'm borrowing this slide from Steve Panelat, which he included this in his webinar that he did for us earlier. And you can see that advanced care planning goes all the way across the time continuum for anybody who's 18 years or older. And on top of that is primary palliative care. And so that's palliative care kind of everywhere within the healthcare system. And then you've got, for people with more specific palliative care needs or a little bit need more specialty focus, they have consultative palliative care. And then at the end, palliative care is the primary focus of care, kind of the hospice model. And for me, when I think about primary palliative care, I think about what happened with my mom. My mom's 95 years old, and she lives by herself in Sun City, a little bit outside of Sacramento. She has no serious chronic conditions. About 6 weeks ago, she fell and broke her hip. She does have a history of falls. It's not the first time we've been around the block on this. The vast majority have not resulted in broken bones. But when she fell and broke her hip, I knew from her previous fall that I didn't want her to go into a foggy mental state. 4 years earlier, she fell and cracked her back. It took her a year to get back into her house because her mind wasn't clear. And that affected her recovery in many ways. So when I got to the emergency department, I was very interested in talking to the doctors and making sure that they knew she doesn't do well on narcotics. She went on a bad drug trip last time. And she told me 10 years ago that it could take her a year to feel normal after anesthesia. So the hospitalist came in first, and we had a conversation about what are the goals of care. We clarified she has no serious chronic conditions. She's not dying of anything. She's just old. So the alternative to fixing a broken hip is letting them lay in bed, and that is just the path that get out of bed is what we want. Staying in bed is not what we want. So clearly surgery was indicated. So then the surgeon came in, and again, I'm like, she doesn't do well with narcotics, and I'm concerned about anesthesia. And he said, look, we do a lot of these hips, and we've really pioneered a new process here. And we will do this without any narcotics. We'll put her on a Tylenol drip. We won't put her under general anesthesia. She'll have regional anesthesia. So she came out of surgery. She blinked her eyes a little bit and looked up at me, and she was alert and awake. 12 hours after surgery, they had her up on her feet. So to me, that's a palliative care. Primary palliative care is that it's so integrated into our system, you don't even know it's palliative care. That they're managing pain, they're attentive to it, they're titrating it to the right amount. They're really doing what they need to do to address the pain and the symptoms, but not over-treating. And being aware of that function, and being aware of time, and being aware about when you're older how fast you can atrophy. So I was very, very happy with the surgery team and the way that they handled the surgery. We have a long way to go with the integration of our healthcare system, because even though they did all that wonderful work within the hospital, they wanted to get her out super, super, super fast on a Friday with a facility who said they had 7 days a week therapy. The first day she was transferred, she walked about 20 feet with her walker. They assessed her. It was another week before, even though physical therapy and PT, OT were coming in, it was another week before that happened again. So we still have lots of room for improvement, but we are making progress. And I wanted to show you this picture because this is my mom like 3 weeks after she fell and broke her hip. She's in the kind of the family area within the nursing facility, and here she is teaching my husband how to play bridge and counting cards. And if you could see the cards on the table, she just put down the ace of spades. And if you play bridge, you know that is the trump card. That trumps everything else. So ultimately, my mom is the one that holds that trump card in her recovery. Now, she needs support, she needs a team, but I was watching her very closely to make sure that she didn't get into delirium or depression. Those were the things that were going to prevent my mom from going home, not rehab. Because I know my mom, I know she has it in her to rehabilitate. But if she gets depressed and gets sleepy and isn't motivated to get up, if she gets delirium, again, it looks like she's just old and she's sleepy and she's recovering from a major medical event. But I could see she'd wake up from sleepiness and she wasn't talking right. So it wasn't just any sleepiness. This was the first step to delirium. And my mom, really, she cannot take any narcotics. And I've even had to advocate with some of my palliative care colleagues who have cared for my mom. Because when she fell and cracked her back, until I got her off of every narcotic, like I said, she was on a bad drug trip. So here's another schematic that we use to help us look at, with the movement, what is it that we want. And we want it to be that every person has the opportunity to explore their wishes for treatment, to express them and put them down in writing, and to have them honored and followed. So exploring it is having the information to think about it, talk to other people about it. Again, Dr. Cassell said, none of us live in isolation, and being autonomous doesn't mean that you have to be on your own. We all live in community and talk with other people and ask for advice. Expressing it is having it documented in a way so that it can get followed, and you don't have to keep repeating and revisiting it unless you change your mind. And of course, we need the system to get the information to the right place at the right time so that it gets followed. And so what do we need? The flip side of those coins are that we need to have effective communities, effective professionals, and effective healthcare systems. So in our communities, we want these conversations to be a normal part of everyday life, around the kitchen table, the water cooler, or places of worship. It's just part of everyday conversation. It's not something that's just put off for this one huge conversation you have when it's under stress or when you go see your trust and estate attorney. And that our professionals have the skills to have these conversations and that they're comfortable in it, that they know how to navigate this. And then our systems need to put into place the structure to help that happen. So somebody has to have it in their job description. They have to have the time to have these conversations. They should be getting the education, the support, so they know how to have those conversations. And they need to get the information that once it's made from where it is to the right place at the right time so it can be followed. I think of the coalition kind of like what our vision of our role and the movement and what we want to have happen in California is like an ecosystem. I think we're a little bit different than a lot of other national organizations out there in the movement. There's a lot of work going on, a lot of great stuff, and we've made particularly a lot of progress around academics and medicine, which is key. But to get us to the vision that we want, that this is just part of life, we need to have a concentrated focus within a community, geographically or virtually or wherever, where we have all these activities going on at the same time. The coalition comes in like coral in the ocean of life, and we bring in fish, we attract the starfish, we attract the mussels, we attract the seaweed, we attract everything, we attract the dolphins, and we attract all sorts of sea life that then becomes the whole community. So you can see them being added there. You can decide which one you want to be, making it all prettier. So one of the things that we did this last year was a convening that we called the Road Ahead. And this started out with the IOM, now called National Academy of Medicine, had produced the Dying in America report looking at the status of end-of-life care nationally. And they found that a lot of progress had been made, but there was still a lot of room for improvement. And the coalition with the California Healthcare Foundation put together a report called Dying in California. I wanted to see, how do we measure up with this national report and the recommendations that they have? And we found that in all of the areas, the 5 areas highlighted in the report, we had made, again, significant progress, but there's still room to make more progress. And so we did a convening with a wide range of stakeholders. Some of you were here. Some of you here were able to participate in that meeting. And looking at kind of helping us to come up with some ideas about where should we focus going forward. And the coalition is still looking at the results of that convening. But another thing we're doing is taking that day and that framework and putting it into a toolkit that people can use in their local communities. So we have a breakfast tomorrow morning for our coalition leaders, and we'll be talking about it there. And we also have an office hours tomorrow. If you're interested in having a toolkit that you can use to convene various stakeholders in your community and get them thinking about this issue and what's accomplished in your community and what you could do going forward and how that fits in with our state perspective, then I would encourage you to be sure to attend those office hours. Another thing we've been doing is looking at design thinking, which is kind of a new, kind of a trendy, but a new interesting way to look at life's problems. And design thinking is being applied in a lot of industries, and it's starting to be applied in healthcare. I recently saw some guidance and a toolkit from the Institute for Healthcare Improvement. So when I saw that, I'm like, okay, this is really kind of becoming more standardized or mainstream than just among the cool few, which we consider ourselves cool few here. But we use the design thinking. It's a way of bringing together a group of people to look at an issue. You first do some research about what's happening out there and how are things going, and then get into a very creative space to come up with some more creative ideas about how to solve a problem, trying to get us out of our usual space. And we did that convening about 6 months ago with some of our e-patients and some of our healthcare professionals, and a couple ideas came out of them. And one is we're calling it Humans of Palliative Care. So I'm giving you a little precursor of one of the things we'll be working on over the next year is taking this concept and turning it into a real serious campaign. The idea is to educate people on palliative care using kind of a parallel to Humans of New York, which is a story-based online movement and a photo-based one that just really humanizes the experiences of people in New York. And so we want to use that philosophy to create this story-based and photo-based campaign to educate people on palliative care. So stay tuned on that one. Another thing we're doing is to look at kind of the standardization for palliative care. So we did that in a couple of ways. And first, you have, I had the chance, with Matt Perry's help from California Healthline, to write an op-ed about the evolution of standardization and definitions of palliative care. And we have with palliative care, there's the broad definition and aspirational aspect of palliative care, but it has to be operationalized. And sometimes we get confused that the operationalization of it is palliative care. So the fact that palliative care is very prevalent in the inpatient hospital setting, that's not the definition of palliative care. Palliative care is the relief of the pain and suffering and the holistic care. But it has been operationalized first in the inpatient setting because that's where we could make progress. And now we want to see it spread across the continuum of healthcare. And California Healthcare Foundation, again, has done a tremendous amount of work in this space. The coalition, with partnership with Blue Shield of California, brought together an advisory group for what we're calling the California Advanced Illness Collaborative, and we have a panel presentation on that more tomorrow. But the first step of this collaborative was to come up with some high-level consensus on the essential elements of community-based palliative care. So when my mom needs palliative care in the community, I know whether she's covered under Kaiser or Sutter or Medi-Cal, that she's going to get a certain floor of services and team and all of that. So that's an example of how we can take some great work and some build off of those payer-provider partnerships that California Healthcare Foundation has had and scale it into a much bigger movement and standardization across our state and our community. So the Pulse e-registry is something that we're working diligently on, and it's going to be piloted in 2 communities. It's a very, I would say in some states, they have a very integrated system. In Oregon, they were able to do it fairly quickly because they layered it on top of an integrated system for emergency responders. They already had a single place to call. So they just added in the Pulse. In California, we don't have that. So the Pulse registry involves 7 organizations as the key elements of it. We have the 2 pilot communities, we have the coalition, we have California Healthcare Foundation as the funder, we have the Emergency Medical Services Authority as the state agency, we have our tech platform, VINCA, and we have Poison Control, which will serve as the call center. So we're very excited about the promise of having the registry, and we're learning a lot, including barriers that we didn't realize existed before. And we're committed to working through those barriers and piloting it again in 2 communities in a way that our goal is to have this spread statewide. So that's something to keep track of. Another thing that took our time, as well as many of you probably in the audience, was the End of Life Option Act, which went into effect in May. So the coalition, we hadn't taken a position on this before it became law. And once it was, our boards had multiple discussions about it and felt strongly that it was important. It is law, so we need to be in this space as a neutral source for information without a bias one way or the other. So we have that information on our website, as well as training, how to have these conversations when you're approached by a patient that's asking about this. How do you handle that? And do it in a sensitive way, that's sensitive both to your own personal values, that person's values, and the team. We have policy advocacy that's been ongoing and is coming up more this year. SB 1004 passed several years ago, and it requires Medi-Cal to instruct the Medi-Cal managed care plans to provide access to palliative care. So the state's been in the process over the last 2 years kind of coming up with the plans for implementation. And we've been there advocating and advising them and writing letters and attending meetings along with California Healthcare Foundation and some of our other leaders here in the audience. So a lot of progress has been made, but we had a little bit of a setback in the governor's proposed budget, which comes out early in the year. He proposed delaying all programs that haven't been fully implemented. And because SB 1004 hasn't been fully implemented, it's slated for delay until no sooner than July 1st of 2018. Prior to this, the plans were on notice that they would need to implement this in April. So we were disappointed by that, but also want to take that as an opportunity, and an opportunity to advocate to the governor's office about the value of palliative care and how it helps us to have better get better value for our healthcare dollar. So it's effective and it's efficient, and it's really delaying it is penny wise and pound foolish. And we've convened a group of about 9 organizations as a collaborative to advocate with the administration and with the legislature to remove that delay. And there's still, the fat lady hasn't sung because the budget process will play out more in May, June, and July of this year. SB 294, we're co-sponsoring that with CHAPCA, the California Hospice and Palliative Care Association. It complements SB 1004 because what we have is a healthcare system that was created incrementally over time looking at discrete patient needs. But it doesn't work seamlessly. And one of the ways that we see that playing out is that hospices can go into the home and provide a range of services, including hands-on skilled nursing, if the person is a hospice patient. They can go into the home and do a range of services for a palliative care patient, but we're not sure whether they can provide skilled nursing. The nurse can come and talk, but can the nurse touch the patient? So this bill gets rid of that gray area and just makes it clear that yes, again, because they're through that licensure, through that organizational structure, through through all of that they already have in place that make it safe and appropriate for a hospice patient, they could do it also for a palliative care patient. And we wrote a letter to Medi-Cal encouraging them to adopt the Advanced Care Planning CPT codes so that you can get paid by, not just by Medicare, but also by Medi-Cal, and they did do that. We have lots of work going on in pediatrics, including the Partners for Children, a waiver, which was the motivation or the inspiration for SB 1004. The waiver, the state has to apply to CMS for a waiver, and they got that many years ago, that allows children to get concurrent palliative or hospice and concurrent curative care concurrently. And the waiver is up for renewal, so that opens up a negotiation process between the state and CMS, and so we're very actively in that space with support from California Healthcare Foundation. Also helping hospices look at kind of best practices around concurrent care and creating additional tools to help with supporting pediatric patients. We do some customized services, and we have worked with UCLA Health, Partnership Health Plan, and Alameda Contra Costa Medical Association. So whatever kind of an organization you are, if our expertise would be helpful to have us come out and work directly with you, we can do that. We're also looking strategically at our business model and how do we make the organization strong for the future. So we have a consultant we're working with who has expertise in nonprofit business models, helping us look at, again, the coalition has grown kind of incrementally based on grants. We've achieved a lot and we've grown quite a bit, but to move up to the next level and to move to that level that we need in order to really create and support a movement, it's going to take a different funding model. Grants fund projects, but they don't fund the infrastructure. They don't fund the continuity between things. They don't grow the effort of bringing in and recruiting new members. So we're looking at what kind of changes we need to make in order to, again, to grow into that larger organization to support this movement that I feel from this community. People are aching for this next phase to happen. So I just want to say, even though it's a heavy lift, our mission here is important. We've made a lot of progress. We have a proven track record. More than 1 million post forms have been purchased in California. And you can download the form. But there's still so much more we can do it. But we